Very good morning to all. I thank Manavi Madam and the team here for inviting me. So I'll try to keep it as simple as possible. If you miss the screening window for ROP, you lose vision. So ROP, as you have already know, is a vasoproliferative retinal disorder that affects the preterm children, and the term was coined in 1951 by Heath. And the clinical course, as you know, varies from spontaneous regression to bilateral retinal detachment and total blindness. So our aim is to catch it somewhere in between these course and then intervene to prevent the vision loss. So in Indian setting, there are a lot of issues which create problem for us. One is unmonitored oxygen use, no lack of use of oxygen blenders and pulse oximeters. And we have higher incidence of the aggressive forms of ROP, particularly aggressive AROP, aggressive ROP. And neonatal comorbidities like sepsis and respiratory distress, anemia, recurring blood transfusions are all more in the Indian setting. And we have a atypical presentation wherein even heavier babies in India do get severe ROPs, published from by Dr. Parag sir. And we have also other challenges like late screening and referrals, limited awareness among parents, pediatricians, and primary healthcare workers. And we have a gross rural-urban disparity in the sense that many of the specialized centers are in the more higher tier cities, uh, and the specialists are also located there, whereas in the rural setting, the screening becomes a challenge, which is now being partially solved by means of telemedicine. And the incidence of burden of blindness is very high, especially because of the preterm delivery rates. As you know, 1 in 8 or 9 children are preterm. And so we have a huge challenge ahead of us, and we are one of the capitals of ROP. And long-term morbidities with ROP is again a challenge, high myopia, strabismus, glaucoma. And there is very poor outcome with late-stage ROP if you catch it, even with surgical interventions. So the screening guidelines previously was lesser. Then from 2017 onwards, our screening guidelines have changed. The Ministry of Health and Family Welfare, RBSK, and National Program for Control of Blindness have issued guidelines. And now the current guidelines are any child with birth weight less than 2 kgs, a gestational age less than 34 weeks, and if the gestational age is between 34 to 36, but with other risk factors, like we have the first three talks, you have heard about all the risk factors which are there. So if they are there, again, you have to screen these babies, the cardiorespiratory support requiring babies, prolonged oxygen, respiratory distress, sepsis, blood transfusions, hemorrhages, apneas, and poor weight gain is again a very important. So when do you have to screen? So the current guidelines, there's a statement that before the child leaves the NICU, they should be screened at least once. Maybe it 10 days or 7 days, still it is better to do once. But otherwise, the standard of care is by 30 days of life minimum, it should be screened. And if a child is particularly very low birth weight or extreme preterm, then they should be screened earlier, like 2 to 3 weeks onwards, they should start the screening if they are in the NICU. So there are two ways that we can screen the child. One, a doctor goes directly, does an indirect ophthalmoscopy, or we do a retinal imaging by trained personnel. As in our guidelines, it is accepted now. The important thing in both the thing is you have to maintain a proper routine. Like if you are visiting a NICU, you have to visit it a particular day, like every week. If you're going on a Monday, you have to keep that routine so that it becomes easier to gather all the babies and nobody misses a screening. And more importantly, whatever you screen, the stage, the zone, everything, you have to properly document. You have to give a correct date and document that also. So we usually stop the feeding half an hour to 1 hour before the screening and make the baby burp. And sorry. And we apply mydriatic drops 2 to 3 times at 10 minutes interval. Half dose of the normal tropicamide plus that we use, 0.4% tropicamide and 2.5% phenylephrine. Usually prepare it by mixing the tropicamide plus drops with the lubricating eye drops. And we use proparacaine 0.5% eye drops for topical anesthesia just before screening. For doing indirect ophthalmoscopy, we have this neonatal size speculum, Alfonso speculum, Sawyer eye speculum, and specialized scleral depressors. And we use a 20D or a 28D lens. And the method, like I said, is reading half an hour before, and then put a drop of paracaine. So some people have the parents with during the screening procedure. In some centers, they don't allow. But it is better to counsel the parents regarding what to expect before you start the screening. So they might get anxious once the child starts to speak. So before this, you say that healthy cry is a good sign, denoting that an active child. And some amount of redness or mild swelling is to be expected. And the speculum marks also you should explain before you do the screening. So you have to provide a safe environment in your clinic for the baby. Warmer, pulse oximeter, and an emergency cart as backup fall is a good practice. And it's always better to have a neonatologist or a anesthetist at a available distance. Good swaddling and hygienic practices, hand hygiene in between cases, sterile instruments are all important. And before you start screening, look for anterior segment problems also. And again, once again, documentation and follow-up cards are very important. So, or the other way of screening is by using a fundus imaging. We have a lot of cameras, most of them are contact cameras, and there are proper again So there are 2-3 advantages of having a fundus camera. Even if you don't have it, you probably but if you have a fundus camera, it can help you. And fourth, Redcam as well as our Indian screenator Neo has 130 to 150 degree of field. But the same is applicable to the precautions you have to take so that you don't produce infections. So you have to remember that it's just maybe a 2-minute procedure or a 5-minute procedure, but you have to remember that you are giving some amount of stress to the child. So there can be fluctuation in their systemic parameters over a transient period, including pain, stress, exhaustion, oculocardiac reflexes, and even the drops that we use. You have to make sure that you don't keep on just because the pupil is not dilating. You should not put 5 or 10 times. You should not keep on putting the drops. So every time you put a drop, then you wait for some time, like you give a dilating drop maximum 2 to 3 times. And you have to give only not a normal dilute. You have to dilute it and give it as a half dose drug. And you have to wipe the excess with a cotton swab so that systemic absorption through the skin and other things are also not there. So even these drugs can cause feeding intolerance, delayed gastric emptying, transient paralytic ileus, oxygen desaturation, apnea, vomiting, acute hypertension, neurological, all these have been described. So you have to maintain the child in an environment where you have again temperature. You have to make sure the baby is swaddled well and that the AC is not on full blast where you are screening. So there are other things for pain management which have been told in literature, and sometimes most commonly we all these sucrose and all we use during our when we do laser or a more extensive procedure. But for this, most of the time we do use a local anesthetic drops and a pacifier, non-nutritive sucking and all are also helpful. And oxygen support as a backup you should have. So where to screen these babies? If the babies are admitted, the best place is the NICU where the baby is admitted. And if the baby is discharged, you can call the baby back to the NICU or to your ophthalmic clinic if the baby is discharged. So when to treat and all will be described in detail in next this one, AROP, zone 1, stage 3, or any stage with plus in zone 1. And in zone 2, stage 2 or 3 with plus. And follow-ups in a simple way to remember, if it is a zone 1 disease which does not require treatment, then you have to keep monitoring for within a week. And if it's a zone 2 disease which is not treatable, then you have to monitor within 1 to 2 weeks, you have to keep following up. And for zone 3 diseases, most of the time you need 3 weeks, once in 3 weeks follow-ups. And we terminate screening usually when the vascularization is complete or the child has crossed the age of 35 weeks with no evidence of ROP, or the ROP has come and it has spontaneously regressed. So just a close up with one case which was brought late, 46-day-old child. You may think it's only 15 days post this one. It was a 1.6 kg child. And during the NICU stay, it was not shown to the ophthalmologist and presented directly in this at 6 weeks. So you can see this. So when it comes as a late presentation, the outcomes may not always be great. So one eye had a successful outcome with vitrectomy, and the other had a partial RIAD under oil. So if you want one take-home message, every preterm child who is eligible for screening should be seen within the first 1 month of life. Thank you.